Good afternoon, everybody. It's my pleasure to speak today about the mimics of malignancy of adnexal lesions. Adnexal lesions, both incidental and symptomatic, are a common finding in clinical practice and pose a challenge diagnostic problems for the radiologists. About 25% of ultrasound adnexal masses have not conclusive using these examinations. And although these lesions have a low rate of malignancy, up to 20%, patients are frequently referred for surgery. So the goal of the imaging modality is to differentiate malignancy from benign lesions. A multidisciplinary approach with physical examination and the diagnostic and tests are necessary for a correct evaluation of an adnexal lesions. Ultrasound is the first-line imaging modality, and in the majority of the case, it can conclude the diagnosis. CT plays an important role for staging, but it has a poor role for the characterization of adnexal mass. MRI, as we'll see in the next minutes, is the most accurate modality for the characterization, and many of the benign adnexal lesions that are not well determined using CT ultrasound may be correctly evaluated using ultrasound. Ultrasound establish a 10 criteria, 10 signs to differentiate benign from malignancy, and using this approach, we can reach a correct differentiation between benign and malignancy in about 80 to 85% of the cases. It's important not only to evaluate the morphologic features, but also to evaluate the vascularization using power and color Doppler. However, there are some findings that are not specific, some of them are most common seen in malignancy, such as solid areas, thick septations, ascites, or the presence of a pelvic ornamental masses. But if you don't see the most of these findings, it's not easy to differentiate benign from malignancy in every case. There are overlapping ultrasound findings between benign and borderline tumors with papillary projections, and there are overlapping ultrasound features of benign massinous cystadenoma and other borderline massinous tumor. The key differential diagnosis issue to differentiate benign from malignancy using ultrasound is first to assess the thickness of the wall. If you see a thin wall and with a pure anechoic content in the cyst, you are confident with a benign lesions. The presence of solid elements increase the risk of malignancy. There are the rule of 1 to 3. 1 centimeter cyst in the first week of menstrual cycle is a follicle. 2 centimeter cyst in the second week of menstrual cycle is a dominant follicle. 3 centimeter cyst in the third week of menstrual cycle is a corpus luteum. Size is also important, and it's also important to evaluate if the patient is pre or post-menopausal. If you found a cyst that is less than 3 centimeters in a premenopausal woman, it's likely to be physiological. If the cyst is bigger than 7 centimeters, it's potentially neoplastic. Follow-up ultrasound in 6 weeks is often recommended to evaluate if there is resolution of a physiologic cyst. And you can find also pain that can be due to a side of a cyst of its torsion. MRI is a better modality in comparison to ultrasound for the characterization, and is used as a solving tool to establish the correct origin of the mass, to differentiate ovarian from extra-ovarian lesion, and to characterize the lesions, especially after ultrasound. With MRI, we have to answer these questions. The first, does the lesion arise from the ovary? Second, is it a malignant tumor? And what kind of tumor is it? In the recent years, an adnexal MRI scoring system was developed, and this score system relies the radiology suspicion to the clinician and can help the standardization of their MRI report. This system analyzes features as lesion component, signal intensity, contrast enhancement, restricted diffusion, the presence of peritoneal implants, and divide adnexal lesions in 5 classes. You can differentiate from 1 to 5. The 5 score is when you see a probable malignant mass. You can assess the presence of peritoneal implants, and we have also to evaluate the dynamic curve of the enhancement. It's important not only to evaluate the morphology of the curve, but also to compare them with the physiological myometrial enhancement. Usually in malignancy, you find a curve that is characterized by a high, rapid increase of the signal, followed by plateau or washout, and the enhancement is bigger or equal compared to myometrium. In case of type 1 and type 2 that are most commonly seen in benign lesions, you see that the enhancement of the lesion is less than the myometrium. You have to evaluate the T2 weight signal, and in case of low T2 solid adnexal mass, you have to evaluate the diffusion. And you have to evaluate if there is a restriction of the diffusion, and the restriction of the diffusion is usually correlate with the malignancy of the lesion in most, but not in every case, and as I show you in some examples. This is a characteristic MRI findings on ovarian cystadenocarcinoma. You see a heterogeneous right adnexal lesion characterized with low intensity on T2 weight images, with restriction of the diffusion, high signal on the b-value with low ADC map. And using the dynamic enhancement characteristic, you see that the lesion showed a increased uptake bigger than the myometrium, followed by the washout. And combining morphology, diffusion, and dynamic characteristics, you can confidently diagnose the presence of a malignant tumor. The second questions that you have to answer when you look at MRI examination, if is the lesion arise from the ovary. It's crucial to differentiate ovarian from not ovarian lesions. Usually, extra-ovarian lesions are diagnosis if you can separate the lesion and you can distinct the ipsilateral ovary. Usually, the lesions are benign, and there usually is a follow-up approach is recommended. This was a case of extra-ovarian lesion. You see the ovary with there is a cyst, and you see another lesions. In the case of intra-ovarian lesions, you see a rim on ovarian parenchyma that surrounds the lesion, the so-called claw sign. and this is the rim of the ovary that surround the lesions. And in this case, you can differentiate physiologic versus cystic neoplasm. Now I'm going to show some examples of ovarian lesion that can mimic malignancy. The first is the massive ovarian edema, that is a rare tumor-like entity, and we see a solid enlargement of the ovary associated with several stromal edema. In this case, you can also detect the presence of a partial torsion, the normal ovary, that is the most common cause of this edema. This is an example. You see the enlargement of the ovary on ultrasound with vascularization that is absent, or you can see the vascularization only at the periphery of the lesions. The pathognomic findings at MRI are the presence of multiple follicles that are situated at the periphery of the large ovary, associated with stromal edema that appears as a high intensity on T2A images. In some cases, you can find hemorrhage that are better seen on the T1 fat sat sequence, and you see a poor vascularization after contrast. Now I'll show you another clinical case, a young woman presented with chronic pain. Ultrasound shows a cystic mass. There is a doubt if the mass originated from the ovary. The markers were negative. I'll show you axial corona T2A images and contrast images T1 in out-phase diffusion sequence. The first step is to evaluate the presence, to detect the ovaries, the normal ovaries. We see the normal left ovary, but we don't see the right ovary. So these lesions origin from the right ovary. We see multiple septations, but we see some areas that dropping signal on T1 out phase comparison with in phase, indicative of the presence of fat, with no restriction of the diffusion. So we are confident with the presence of benign criteria. There is also some hemorrhagic areas. The final diagnosis was a presence of mature cystic teratoma. Malignant transformation of mature cystic teratoma is extremely rare and occurs in postmenopausal women. In some cases, you see carcinoma arising from the cystic wall. Another clinical case with the presence of a left ovarian lesions that show hyperintensity on T1 in phase and out phase images. So we are confident with the diagnosis of hemorrhagic lesions, no fat components. T2A the images shows the presence of a regular border of the cystic lesion with the presence of fluid levels. This is the characteristic signs due to the recurrent hemorrhage. And we will see in the same patients also another lesion on the contralateral ovaries that show hyperintensity on in-phase images, but drop in signal on out-phase imaging. We are confident with the presence of fat component. So the final diagnosis was a left endometrioma and a right dermoid cyst. It's important to evaluate the presence of fat and hemorrhage in the lesions, and MRI is better than CT to detect this component, to differentiate this component. And I'll show you the typical shading signs that is characteristic of endometrioma. You see the hematic and fluid levels. And so if you detect these findings, you are confident with the diagnosis of endometrioma. This in some cases can be seen also in other lesions, but in most of the cases is characteristic of endometriosis. Another case, axial coronal sequence. You see the large pelvic mass. We can detect the left ovary, but we don't see the right ovary, so we are confident that is a mass origin from the right ovary with no contrast after gadolinium administration. We see the subtraction images with no absence of contrast. This was a case of ovarian fibroma. It's the most common benign solid tumors of the ovary. There is well-defined mass with low signal intensity on T1 and T sequence. In some cases, you can see some heterogeneous area on T2 sequence with no sign of enhancement after contrast administrations. Now we move to evaluate the extra-ovarian adnexal mass. It's important to evaluate if the mass is connected to the uterus. We have to evaluate the pregnancy status of the patients. We have to know if there is elevation of inflammatory laboratory test, fever. We have to evaluate the mass of the morphology of the mass is tubular, and you have to evaluate the relation of the mass with the ovary. If you, in case of the big signs, the mass arising from the ovary, if you don't see these big signs, the mass is of extra-ovarian origin. You can see this the big sign indicative of ovarian origin of the lesion. This is the close sign that is typical of uterine fibroma, as well as the presence of bleaching vessel signs. This is indicative of pedunculated uterine fibroma. Cystic fibroleiomyoma is the most common solid adnexal mass, and in some cases, cystic degeneration may mimic an ovarian cystic lesions, but we have to evaluate the relation of the mass with the uterus. You see the breaching vessels, so are confident with the diagnosis of cystic leiomyoma. Peritoneal inclusion cyst is another benign lesion that in some cases can mimic a malignancy. In this sample, the pseudocyst appear extremely irregular in shape, and usually the cyst invaginate the ovaries. You can detect the ovaries that are usually inside the cyst, and you can see this sign on ultrasound, but also on CT and MRI. And MRI is helpful to identify the ovary within the cystic mass, especially for the multiplanary imaging capabilities. I'll show you this another case. This patient underwent ultrasound that detected an right adnexal lesions. After ultrasound, MRI was performed for a better characterization. First step is to evaluate if the origin of the lesion is from the ovary. So you have to evaluate the presence of normal ovaries. You see on coronal plane the uterus, the left and the right ovary. And the lesions there are not connected with the ovary and not with the uterus either. So this is a no ovarian lesions. We perform diffusions with the presence of restrictions. So we are indicative of malignancy of tissue lesions with poor and heterogeneous enhancement after contrast administrations. This was a case of a pelvic schwannoma. Now is another examples of extra-ovarian adnexal mass. So you have to evaluate the morphology. If you see an ovoid tubular lesions, the more common in diagnosis is a dilatation of the tube. You can differentiate hydrosalpingitis from pyosalpingitis, evaluate the content of the tube and the presence of enhancement that are usually associated with inflammations. And these other examples of pelvic inflammatory disease. You see the presence of multiple bilateral ovarian fluid lesions, ultrasound with irregular septation on CT, and with involvement on the ovary and the tube as well. MRI is better to evaluate the presence of ovarian and tubal abscess. And you have to know that the ovarian abscess appears as a restriction of the diffusion. So you can see a lesion with restriction of the diffusion, or also in inflammation, not only in malignancy. In this other case, we see an ultrasound that shows the presence of a large periuterine lesions with vascularization on color and power Doppler. And the MRI was performed for a better characterization of the lesions. MRI shows the lesions as a hypointense signal on T1, enhancement that appears as heterogeneous, with on sagittal planes, we see the hyperintensity areas with a swirled appearance, and the lesion extends from the pelvic to the perineum. This was a case of agrexis angiomyxoma that is almost found on the right side. Diffuse infiltration of ischiorectal fossa is characteristic. This neoplasm in case must not obstruct urethra, vagina, or rectum. And the characteristic sign that the lesion extends the level of the perineum. So you can differentiate an ovarian from non-ovarian lesions, evaluate this extension that is characteristic of this tumor. So to sum up, imaging plays an important role for differentiate benign from malignant lesions that then can help the management of these patients. Ultrasound is the first line imaging method. In case of not conclusive ultrasound, MRI should be performed. Recommended to use a morphology, diffusion, and dynamic imaging characteristic provided by MRI to differentiate malignancy from benign lesions. And the first step when you read an MRI examinations is to detect the ovaries. If you detect the ovaries and the lesions is not related with the ovaries, you can easily differentiate ovarian from non-ovarian lesions. Thanks a lot for your attention.